Hey everybody, welcome back to another video in our nephrology section on acid-base physiology. So now we're going to talk about arguably the most tested acid-base disturbance at this level, and that is that of metabolic acidosis. So what is a metabolic acidosis? Acidosis is a state of excess protons being created or formed, or a loss of bicarbonate. Remember not to confuse this with acidemia, which is our overall pH in the serum or in the body. So if we look at our primary mechanism here, it's a decreased pH due to increased hydrogen protons or decreased bicarb. Really associate these hydrogen protons with a change in our acid levels, and then our bicarb is more of a change in our base levels. So overall what happens here is that we get a decrease in pH due to an overall decrease in bicarbonate concentration. So this can happen in the two ways we discussed. So you can either increase hydrogen protons or you can decrease bicarbonate. It's all about concentrations here. It's not about total value necessarily. It's about how much of there is one relative to the other. So then the body wants to act to recreate homeostasis, which we always talk about. And how is it going to do that? If we're in a metabolic acidosis, we need to get rid of some of that acid. And so we're going to hyperventilate in order to decrease our CO2. And so when our body senses this increase in hydrogen protons or decrease in bicarbonate, it's going to respond by decreasing PCO2 as a compensatory mechanism, or what we call compensation. And you might be asking yourself, why is that? And it actually has to do with a chemistry equation, again, trying to maintain equilibrium in the body. So if you recall, our body essentially has a buffer system in the blood and in the serum so that we can maintain our balance of protons to bicarb, etc. So you can see over here, we have an elevated level of protons and we want to decrease the protons in the body or decrease our acidic state. We need to shift the equation to the left. And the way that you do that is by decreasing CO2. So if we hyperventilate and we decrease the CO2 over here, that's going to disrupt the balance so that we can actually shift the equation towards the creation of CO2, which is going to lead to a drop in our hydrogen protons. This is helpful, right? Because we just said that hydrogen protons is one of the primary ways that we can get a metabolic acidosis. And that is why hyperventilating is the appropriate compensatory mechanism here. So next we're going to move on and talk about what are the types of things that can cause a metabolic acidosis. And remember from the first video, the overview, we talked about this thing of the anion gap. So the anion gap is essentially talking about the balance of positive cations versus negative anions, and there are various physiologic processes that can actually increase the amount of what we call unmeasured anions that can cause an increased anion gap overall. It's important to calculate the anion gap using the equation sodium minus bicarb minus chloride, because this allows us to categorize our causes into two different groups. We can have an elevated anion gap, which means it's greater than 12 milliequivalents per liter. In addition to the anion gap, you can also get a normal anion gap, sometimes called a non-anion gap metabolic acidosis, which is between 8 and 12 milliequivalents per liter. So whenever you get a question and you determine, yes, this is a metabolic acidosis, you see the pH is low, you see the bicarb is low, the next thing for you to do is look at the serum lab values, which will be given to you, and calculate what is the anion gap that is there. Because then if you do that, you can basically categorize it into two separate groups and say, here are the causes of elevated anion gap, here are the causes of normal anion gap. So we're going to go through each of these one by one, and I just want to give you kind of a high yield point to keep in mind, an important association that I want you to make with each of these causes. Typically that's the thing that they will mention in that practice question, and they will expect you to kind of know which go with which in terms of associations. So the first is going to be methanol, which is an alcohol that is used in antifreeze, and they can get metabolized into formic acid, which is toxic to the body. The key kind of buzzword here, if you will, is that this can present with visual symptoms. So if somebody presents with a metabolic acidosis and they also have complaints of visual disturbances, this is the one that you should be thinking of right off the bat. The next cause is uremia. So kidney disease can cause a variety of problems, but uremia specifically is a cause of metabolic acidosis, because anytime we think about kidney failure or uremia, we're thinking about an inability to properly manage our electrolytes, and thus it makes sense that this can cause an electrolyte disturbance, and in this case it's a high anion gap metabolic acidosis. The next one is diabetic ketoacidosis, sometimes just called DKA, and the association here I want you to know is type 1 diabetes. And in DKA, we essentially create an acidic state in the body because our physiology is out of whack to the point that we are creating a bunch of keto acids in the body. Naturally, that is going to drop the pH as these are acidic. The next one we're going to talk about is that of propylene glycol. So again, this is a problem because it can get metabolized into something that is essentially very dangerous to the body. And in this case, it gets metabolized into lactic acid. Yes, there are many physiologic states where we build up lactic acid in the body, but if you have an ingestion of these substances, you can essentially overload the system and have too much lactic acid, which can be a problem. Key differentiating factor here is that you notice I put no visual symptoms and more so of CNS depression. So you can compare this one versus methanol, which would have visual symptoms, and that would be a difficult question, but they could essentially give you a classic case of metabolic acidosis, and the only differentiating factor when they ask you what's the cause of this patient's condition is whether or not they had visual symptoms or not. And thus, that's why I highlighted this as such an important thing for you to keep in mind. With methanol, we do get visual symptoms, but with propylene glycol, we would not expect to have the visual symptoms present in our patient. The next cause is iron or isoniazid overingestion. The pathways and the pathophysiology of how this works is not as important for us to know for answering questions right. I just want you to be mindful of this as a common cause of high anion gap metabolic acidosis, and this would present when they talk about a patient that maybe took some supplements that were unmarked. They could sometimes talk about a child that got into their grandmother's cabinet and took some supplements. They could have been iron tablets, and they could also be talked about with patients who are naturally being treated with INH, such as patients who might have tuberculosis and potentially they had an overingestion at some point. So that's how it would present in a board style of question. The next cause is that of lactic acidosis. So I put that there are various causes here, but remember back to our primary understanding of kind of cell physiology, and that we have two pathways, right? There's the glycolytic pathway that can then go on to the Krebs cycle and ultimately oxidative phosphorylation. However, there's a secondary pathway where things can get shunted to actually create lactic acid as well. So any process that disrupts this oxidative phosphorylation, whether it's medications or hypoxia or liver failure, anything that disrupts the ability to do oxidative phosphorylation is going to cause an increase in lactic acid in the body. So why does that cause an elevated anion gap? The reason is that while lactic acid is not necessarily charged itself, it does have protons hanging off of it. And if this proton unbinds, it can create a different molecule called lactate, which actually is negatively charged. So you can see how this negatively charged molecule adds to our anion gap, and thus it's a cause of elevated or high anion gap metabolic acidosis. The final thing that's high yield to remember here is what's a very commonly used medication that can also have an adverse effect of causing lactic acidosis. And that's right. The answer is metformin for patients who have diabetes. It's a very commonly used drug, and it's something we need to be mindful of in checking their lab to make sure that they don't develop a metabolic acidosis upon starting the medication. Next, we'll talk about ethylene glycol and its toxic metabolite, which is oxalic acid. So ethylene glycol is interesting in that it's also found in antifreeze, similar to the first one that we talked about with methanol. One of the key things they're going to use here to clue you in to ethylene glycol, is the thing that they're wanting you to pick for the answer, is these calcium oxalate stones. And this should make sense to you because if we have an increased amount of oxalic acid, this can increase our risk of having these types of kidney stones. Also, they might mention that there's a sweet breath smell from ethylene glycol. This is an important differentiating factor from propylene glycol, in which we would not expect her to have this sweet kind of fruity smell coming from the patient's breath based on it being a different substance without that property. So I'll actually add that here, no sweet smell. And finally, one of the last things that we need to know for the high anion gap metabolic acidosis is salicylates, which is a delayed response in that it uncouples oxidative phosphorylation. So I said, right, anything that affects the electron transport chain is going to shunt our glycolytic process to create more lactic acid, right? We have to do more anaerobic respiration. And a key point here I want you to notice is that I put this as a delayed response. What's the reason for that? The reason is that we will actually see in an upcoming video on respiratory alkalosis, the acute response of salicylate toxicity is actually to stimulate our respiratory drive, and this can cause this respiratory alkalosis. But a delayed response, something that might take 6 to 12 hours probably, is to actually cause more problems within the cellular level in causing this uncoupling of oxidative phosphorylation. So this makes for a good test question, right? Because it's kind of tricky in that it can actually cause two different things. Early, it can cause a respiratory alkalosis, and later on, it can actually cause a metabolic acidosis. Always be thinking about these types of things. When I'm studying, I like to think, what would be a good question? What would really test a student's knowledge and test their information and deep understanding of the material? And this is a good type of question that can be asked because it assesses, do you just know the memory aids and the mnemonics that we have for metabolic acidosis? Or do you understand the physiologic process of salicylate toxicity and that it stimulates respiratory drive early on and then it eventually causes cellular dysfunction later? So that's what we have for our elevated anion gap metabolic acidosis, and you can see that the memory aid here that's most commonly used is mud piles. Now we're going to move on to a normal anion gap, or sometimes called a non-anion gap, and the memory aid we use for that is HARDASS. So we have HARDASS. The H stands for hyperchloremia or hyperalimentation. So remember back in some of our previous videos, we talked about how there's always this balance between intracellular and extracellular charges. So if we have a high level of chloride outside of the cell for whatever reason, or hyperchloremia, this is going to offset our homeostasis. We have too much negative charge outside of the cell. So the body is going to work to put some other negative charge inside of the cell. And in this case, it's bicarbonate. So to regain our balance of positively and negatively charged anions outside of the cell, the body is going to make an exchange. And this is why it makes sense that this is a normal anion gap, right? We're trading an increase in one anion for the other one that we're putting inside of the cell. So overall, there's not a change in extracellular anions. We're just changing which ones are located where. This is different than if we didn't put bicarb inside of the cell. Now we would have an increase in overall anions outside of the cell, but that's not what we see here. The reason hyperalimentation can cause this is a similar way in that when we give somebody this intravenous supply of food, the cations are absorbed, but it creates a state of high chloride level in the body, causing a similar effect. The next one that's really important to know is Addison's disease. So remember, at Addison's disease, we have an adrenal insufficiency, and that's we secrete less aldosterone. And we know that when we secrete a high amount of aldosterone, we bring back our sodium in exchange for our potassium and our hydrogen ions. We talked about that a lot in our nephron transporter series. So if we don't secrete aldosterone, we have the opposite effect in that we don't secrete hydrogen protons, and thus it can build up in the body. There are also a variety of ways that renal tubular acidosis can cause this condition. We're going to have a whole bunch of videos at the end of this chapter talking about each of those in detail, so check those out. Diarrhea is an important cause of non-anion gap because a loss of bicarbonate is going to cause an overall decrease in our base level. We said associate bicarbonate with our base, and thus it makes sense that it can cause a metabolic acidosis if we're losing a bunch of our bicarb or our base as diarrhea. Next, we have a couple medications that we need to know about. So acetazolamide can cause a decreased reabsorption of bicarbonate based on its mechanism. Again, similar thing here is that if we decrease our bicarb levels, this is a way we can get metabolic acidosis. We will also talk about this in the pharmacology section. And the next medication we have is spironolactone. Thinking about the mechanism here, this is an aldosterone antagonist. This is known as a potassium sparing diuretic. So it's going to block the effects of the aldosterone molecule, and thus we're going to get a pretty similar presentation of what we'd have in Addison's disease, which is we're decreasing our reabsorption of sodium, and thus we're decreasing our excretion of potassium and hydrogen. Retaining more of this hydrogen molecule is what causes the metabolic acidosis. And the final one we're going to talk about is saline. So when we give somebody saline or fluid, we are going to do two things. One is that we give them a bunch of chloride molecules, and we just talked about right here how that's going to cause bicarb to shift inside of the cells. And two, this is going to indicate to the body that we have a bunch of fluid, right? So we don't need to stimulate the RAS system. If we don't stimulate the RAS system, we don't secrete aldosterone. And the same thing happens what we just talked about with spironolactone. Decreased aldo equals decreased sodium, which then increases our hydrogen and potassium levels in the body overall. All right, so that was a pretty dense video. Go ahead and watch it again if you need to. Also, I think if some of these things were not making sense to you, I would check out the nephron transporter series where we really dove into the effects of aldosterone and how this affects sodium, potassium, and hydrogen. I think that can also provide some additional clarity as well. Great job on this one. I'll see you all in the next one.